name is Manj Goel, vascular surgeon from Cambridge University Hospitals, and also a member of the Venous Executive Board here at Charing Cross. And it's my pleasure to be here with Stephen Black, Professor of Venous Surgery at King's and Tecumseh Hospital. So Steve, as we're approaching the end of another busy Charing Cross meeting, what are your reflections on the venous program from yesterday?
Manj, I think we had another really interesting day of discussion, and I think that's been the strength of this meeting over the last several years. As we've collectively tried to build up the content in the program. What I enjoyed most was the really insightful, balanced conversations we had from a number of people on the podium, where you can see the maturity of the thought processes that have now started to come out, and how we face the challenges of treating patients with venous disease.
The pathway section of the program yesterday I thought was particularly powerful. It's very interesting how in different healthcare settings around the world, private healthcare, state healthcare settings, different continents, the same challenges exist, and venous patients tend to be deprioritized in healthcare systems, but lots of good practice and lots of good ideas. What are your thoughts?
I think that's totally right. It's reassuring that everybody struggles with the same thing to some extent, that it's not a one place issue. But what I thought was striking was the clear efforts that a number of people are now starting to make in solving those problems, with some really striking examples of established care pathways now that are bringing patients into the system in a better way, where they're going to get the treatment that they need and they get the follow-up that they need. And those have all been barriers to ultimately successful treatment in the past.
Let's move on to some of the clinical aspects of the program. So the deep venous program, there was a big focus on stent maintenance and reinterventions and choosing good candidates for stenting as part of the challenges theme. What are your main reflections on the deep venous part of the program?
Well, I think that was right. I thought the conversations were really reflective of what is now 10 years of evolution of venous stenting, to look at that process of the initial excitement of new technology, and as that beds in, you start to experience the pros and cons of the new treatments, and particularly plotting the way through that we need to keep in our mind that venous patients need 50 years of looking after, and we have to figure out how we're going to make that work. And I think there were a number of really interesting points that came out of that, and that move towards stent maintenance that is really important now.
Yeah. A number of the polls were very interesting, and again, the emphasis on high quality surveillance, stent maintenance, but particularly the inflow assessment evaluation. And I think you're right about the innovation. It's human nature to be excited about novel technologies, but once the data come through, we have to learn from them, and as you keep saying, try to make new mistakes and not repeat the mistakes of the past.
Yeah, I agree with it. I think the challenge is when we have a field that is relatively small in terms of numbers, it takes a long time to accumulate the collective experience that allows you to make better decisions.
Yeah.
As the sayings go about swallows in summer, we can't judge our decision on one or two incidences, but once you get that broader experience, you can see that we're all starting to learn together. And I think what was really clear was, through all the speakers yesterday, there's really good, consistent, common themes around patient care starting to come, which tends to suggest we're finding answers to some of these questions.
Yeah. Talking of innovation, we did have some novel technologies presented on the podium yesterday. The ultrasound artificial intelligence technology from ThinkSono, but also the new data from the implant, deep venous valve implant from Inveno. What are your thoughts on these new technologies?
Well, I mean, it's exciting to know there's new things coming, aren't there? Because we need to innovate, and there's different themes in both of them. ThinkSono is the promise of AI, and are we going to get something that delivers on that promise? I think the technology is clearly interesting. It's clearly evolving. I think they've learned lessons from their original study that wasn't as strongly positive as we would have hoped. But if those changes deliver what they wanted to do, then what we can hope for is better care for patients with deep vein thrombosis. And ultimately, that diagnostic step is the first point that has to be met to allow patients to be treated. If we miss that, then there are problems. So let's see. It's interesting. There's some work to be done for sure, but it was really interesting. I think the valves have been the holy grail for such a long time, and this seems to be about the first time that something actually may work. But again, we've got to wait to see what that long-term data shows. And the big challenge for valves has always been showing you can show something works in a patient. What we need to see is that consistent translation to long-term clinical benefits. And the in vivo data does seem to be pointing in that direction.
Yeah, I couldn't agree with you more. And we come full circle back to the pathways and the case selection. We have excellent superficial venous treatment options and approaches. We have a very established deep venous stenting pathways. And the challenge for the deep vein valve is going to be to work out where it fits in the context of these much more established technologies, and what the ideal patient group is going to be, because it would be a real shame for the wrong patients to be getting a new technology that don't necessarily benefit, and for us not to realize the full potential advantages.
Yeah. Oh, that is, again, coming back to the point of data and collecting big data sets. We have had some conversations in this meeting about the European EVA registry, which I think is the kind of steps we need to see, that we are collecting enough data from enough centers to inform our decision making much faster than single center experience ever can. And I think that's where we will figure out some role for the valves, because we know that venous patients are so heterogeneous. There are so many variables that we have to think through. To find the right treatment for the right patient is going to take some time. And perhaps, again, this is where AI might start to show some benefits.
What is great is that there's a real appetite for the venous community to contribute to these sort of collaborative endeavors.
Yes.
And that's what we're definitely going to need. I mean, in the superficial space, I had the honor of presenting the latest VenaSeal Spectrum results. I mean, this study has been 8-9 years in the planning, and I think it's a real positive reflection on the outstanding teams that perform these research across many centers and continents, which is great. And again, another good option for us to treat patients with C6 disease with cyanoacrylate glue. How do you see the superficial space at the moment?
Yeah, I agree. The superficial space feels like an area that is much more established, where we've been treating patients for a long time with technologies that by and large work. And therefore, it was harder to see where innovation would really challenge things. But I think with cyanoacrylate, a lot of the issues have been dealt with. There's some clarity in the data. There's real commitment to big data series. I think Ramon Varco made the really clear point about challenging some of the unfortunate messaging that had got on around cyanoacrylate, and you have a system that clearly works, and it is safe, and it delivers results. Obviously, again, patient selection is the key. There are people who would benefit from other technologies, and I think making sure we have options for patients is a good place to be.
Yeah, we have many options in the toolkit, which is very good, and perhaps a discussion around a topic that we've had lots of conversations around, which is foam sclerotherapy.
Yeah.
The role of foam sclerotherapy in the complications. What insights did we get yesterday from presentations about complications from foam?
Well, again, foam is now well established. It's been used for many years with a great deal of success, and I think the big thing about foam is it is something that can be used everywhere by anyone, and is very scalable and is cheap. And if we're going to try and make sure we deliver ulcer care for patients, then foam clearly has to be at the forefront of dealing with that. And so the conversations about subulcer plexus foam sclerotherapy, about making sure that you get the dosing right, the complications are kept low. There are really consistently clear ways to deliver that now. And I think we've seen some good data, and data will continue to emerge around subulcer plexus foam, which I think is a key component of treating patients with ulcer, and hopefully that message is now going to be more broadly delivered.
Yeah. Mechanical thrombectomy is something that came up a lot yesterday. There has been a real shift away from the use of thrombolysis, certainly in high volume centers. I think there is still a bit of doubt about what the role of early thrombus removal is and how far we can push the envelope in terms of thrombus chronicity. What did we learn about this topic yesterday?
Well, at Charing Cross now we've incorporated pulmonary embolism into the venous program, which I think is a good move. I think there's a much bigger interest now in treating PE, and I would say that with the mechanical thrombectomy options that now exist from both companies like Inari, Penumbra, and others, there is are now really well developed treatment options that work quickly, work safely. We saw data presented first in Podium on the use of Penumbra. The safety rate was really exceptional for a very high risk group of patients. We've seen similar data presented from Inari with their Peerless study, shows really safe procedures delivered in an efficient fashion. So for thrombus removal now, I think it's pretty clear that mechanical devices have evolved to a point where minimizing the use of lytic, I wouldn't say eliminating it, but minimizing the use of lytic has enabled us to push the safety and the efficacy of treatments in a really strong direction. And hopefully that will start to translate with data that will come from a number of studies that are ongoing to give us that evidence base to really move that treatment forward. But it's clear that mechanical now is here to stay, and those are the treatments.
And it's a very logical transition and a logical advance in the treatment, which is also great.
Yeah. My reflection on the technology that we've seen over the last 24 hours, Manj, is that growth in moving away from simply having a balloon and a stent and seeing that as the end for our patients to understanding that stent maintenance process. And I was particularly excited by the device that Jerry O'Sullivan presented yesterday from Intervene, which will help us to debulk in-stent stenosis in venous disease, which is a really distinct pathology from the arterial process that we've seen before. And I think there's a number of exciting technologies that seem to be emerging in that space, including Bullfrog, which Maketa presented yesterday, and others. What do you think about that evolution?
So I agree entirely. I think the concept of injecting steroids around the vein is unique and actually addresses what we have known for quite some time, that inflammation plays a big role in poor outcomes in these patients. So definitely a space to watch.
So if there's one message that I think everybody needs to know from yesterday, is we need to keep working on delivering patient pathways that get patients to where they need to be to receive treatment that makes a difference to their venous disease.
I agree entirely. The teams and the pathways make as much difference than the actual procedures themselves. So teams and pathways are as important as the technique. In the last few years, it's become very clear that the venous patient population is unique and requires special attention and special expertise. What are your thoughts on this concept, Steve?
I agree, Manj. I think it is absolutely clear that venous treatments are not simply an extension of arterial treatments, and the distinction in pathways, algorithms, patient populations, and long-term follow-up of patients in particular is becoming increasingly obvious to those of us involved in this treatment process. And in particular, I would emphasize venous patients need care delivered that will last for 50 years plus of their life. That is not something that has ever been a thought process in arterial disease.
So we've covered pretty much all the program. Again, it was a very engaging day. Lots of new numbers and new data for people to follow, and I'm sure we'll be discussing this for weeks to come. So
yes, it was a good day.
Yeah.